we are now entering into the recent, let's say, advancements. So other examples of studies and novel methodologies that have been introduced. Okay, so Nicolas from Bordeaux, pharmacist. This I know.
Yeah.
This I know. So this time I did it right. Yeah, and please go ahead.
Well, thank you very much. And thank you for hosting this event. I mean, you have a fantastic audience and panelists, so thank you very much for that.
Let me say something. So if you are tired or just take 1 minute break, remember that there is coffee and water and whatever in the back, so we can continue staying.
Yeah, but I guess it's too late for me, right? I need to
No,
talk.
I can get a coffee.
But that's okay. So let's start. So very surprisingly, I will speak about validation and validation of validation, and I will do that in the French context. So I wanted to start very simple, and I will summarize what everybody said just before. So how do we conduct a validation study? So you start from your database, then you have a case identification algorithm or a code set, a phenotype profile, whatever you want. At the end, what you have is cases and non-cases, right? And usually what you do is that you return to a more reliable diagnostic source that can be medical charts, that can be register. It's what you consider your gold standard. And starting from this point, you do your abstraction and your case adjudication to define all the indices and performances value that you want, and we spoke about it earlier. In France, there is something which is very special, and it's not specific to France. We have that in many countries in Europe, is that you are not allowed to go back to your patient data without the patient consent. Meaning that when we are doing a study on the French nationwide claim database, we are not allowed to perform such validation study in this way because we are not allowed to go back to the patient medical charts. So we have to be creative. In France, we have a very famous sentence, which is, in France, we don't have oil, but we do have good ideas. That's from the 70s during the oil crisis. So we try to apply that to case validation, actually. And so we realized that we have very, very strong and very, very powerful database in France. And so the French nationwide healthcare database, which is called SNDS, for Système National des Données de Santé, cover the entire French population, 99% of the population from birth to death, with no gap in it. So we have everything which is reimbursed by the French healthcare system, which is very broad. So as you can see, you have medical procedures with the dates in inpatient and outpatient setting. You have the hospital stays with the duration of the hospital stay and the discharge diagnosis. You have the lab test and the imaging procedures, but without the results. You have all the drug and medical devices that have been dispensed in the French settings, and you have all the medical and paramedical visits. So if the patient go to see the general practitioner or the nurse, we have it. And so we said, well, look, since this is very rich, why don't we reconstitute electronic health records? And it's actually what we did. So we de-identified we removed the identifying information from that. So we changed the date to age class. We changed the date of healthcare encounters by relative dates. And at the end, we had this kind of records. So in this example here, which is about pulmonary embolism, you have the hospital stay for pulmonary embolism that lengths for 5 days. And you can see that at day 1, the patient had a Doppler ultrasound of the lower limb, and then 5 days after, he get a dispensing of anticoagulants, followed by a visit with the general practitioner, and we can see that he refilled his prescription 1 month later again with anticoagulants. So we have a body of proof, we have clues about what really happened just looking at the claims in this way. And so we decided to use that again to try to do a case validation. So we start again with our cases and non-cases. We randomly draw 100% of each group, abstraction, and then we reconstitute the anonymized electronic health record on that base. And we ask 4 physicians, 2 pairs, to blindly adjudicate our case to be able to define who were the true positive, false negative, and true negative based on this reconstituted healthcare record. So I know that this slide is very dear to Rosa's heart. So this is how we derive negative predictive value and positive predictive value. I mean, It's not rocket science, it's very simple, but what is very interesting for me at least is that, as Vincent said earlier today, once you have your NPV and your PPV, and once you have your observed prevalence in the sample, you are able to derive your sensitivity and your specificity. So that gives you a lot of clue to ascertain about the robustness of your algorithm. Few conditions, and we may have more conditions to apply this kind of approach, but the two most important for me, and the most important for me, it's the first is that the outcome of interest must be managed by a specific sequence of care and encounters. So venous thromboembolism or cancer, for example, are very good example because, well, when you have a cancer, you need to go at the hospital, you have a large bench of diagnosis procedure, you have very specific drugs. So that gives you a lot of confidence when you are assessing reconstituted healthcare records. And the second point is that you can do this kind of démarche, this kind of application in healthcare database that can capture in an exhaustive way and a sufficient number of medical elements. So again, when you are speaking about cancer, if you are just dealing with a primary healthcare database with no information about the procedures that have been performed, with not a full record of everything that was prescribed by each practitioner for the patient, then you are missing some pieces of information. So that doesn't give you an exhaustive record of everything that have been performed around the patient. So we did that for quite a few outcomes, actually. So we started the first time, it was for metastatic castration-resistant prostate cancer, mCRPC. We did that also for relapses in multiple sclerosis. The more recent example we did was for venous thromboembolism. So we published all of that. And I know that our German colleague from BIPS applied the same approach for acute myocardial infarction, stroke, and cardiovascular death in GEPARD. And so this is the illustration of what kind of indices we have with this kind of approach for the example I've just quoted. So as you can see, most of the time we have very high positive predictive value. So that can be partially explained by the fact that when we are doing this kind of validation, there is an iterative process where we try to improve the algorithm. So usually at the first attempt, we realize that we have missed some points in the algorithm. So based on the comments of the experts and the physician reviewing the cases, we change and we adapt the algorithm. And at the end, we got this kind of results. But I agree that that can be discussed because it's almost perfect, and nothing is almost perfect except Rosa, perhaps. But yeah, so we try to validate our validation process. So to do that, we will focus on the relapse in multiple sclerosis. So to give you some piece of context, so it's an algorithm that have been designed in a study to assess the comparative effectiveness of dimethyl fumarate on the onset of multiple sclerosis relapse. That was an industry-funded study. So we did that in the SNDS, so in the French claims. We select a population of multiple sclerosis patients. And so the algorithm was defined based on hospital stays with or without high-dose corticosteroid administration, and on the dispensing of high-dose corticosteroids in outpatient settings, so outside of the hospital settings. And as I said, we had a 95% positive predictive value and 100% only negative positive value. So what we did is that we choose. Oh yeah, sure.
How did you select the MS sclerosis population? Because and I am asking this because we will get back to this in one of the next presentations.
So if you really want more details, you have to ask to Laure, which is connected online, because it's her study and not mine. But basically, we relied on, well, the hospital discharge diagnosis codes, and you have very specific also drug that are used in multiple sclerosis. Of course, because as you know, in the French database, we don't have outpatient diagnosis codes. So we almost always rely on drugs dispensing. So we select the population of multiple sclerosis patients. We have this algorithm. And so what we did at the second stage is that we try to find the gold standard, which was for us the prospective clinical database of the French Multiple Sclerosis Observatory, the OFSEP, which hosts actually a multiple sclerosis dedicated electronic health record, which is populated by neurologists following a patient visit. So the information I collected at the time of the visit at the neurologist, but also in a retrospective fashion, meaning that if you go to see the neurologist in December and you had a relapse in, let's say, summer, it will be captured, right? Inside you have clinical evaluation and you have all the neurological episodes. So we perform a linkage between this database and the SNDS, because I said earlier that you cannot retrieve data from the SNDS to another database, but you can do the other way around because you have the patient consent, right? So patients gave their consent in this database to see their information linked to the French claims. And we replicate in this linked population the population of the initial dimethyl fumarate study, right? So we apply the same inclusion and exclusion criteria. And then we assessed the consistency between the algorithm identified cases and the offset recorded cases with, because I know that people love sensitivity analysis, we did that with a time frame of 30, 45, and 60 days. And so now these are the results. So very surprisingly, the PPV and the NPV are slightly, I mean, perhaps not slightly, but are lower than in our initial validation study based on reconstituted electronic health records. So the NPV is pretty much stable, around 90%, but the NPV increased with the time frame, reaching 68% at the end. So of course, there are many points to discuss. The first point I would like to highlight is that you know that NPV and PPV depend on your sample, right? That can vary according to your sample. So although we selected the same, I mean, although we use the same inclusion and exclusion criteria to select our population, still the assessed population may differ. We don't have exactly the same people that have been randomly drawn, so we may have some kind of discrepancies. But the true question for me, and that's a question I also asked to you, is who is right, right? Because in one hand, you have the French claim database covering the overall French population, collecting prospectively and exhaustively all the reimbursed healthcare expenditure in France. And in another hand, you have the OFSEP, which is the annual age registry of of multiple sclerosis in France with very detailed clinical information. So for example, you can say in the SNDS, okay, but is a high dose corticosteroid dispensing in the SNDS always associated with a relapse? Because you can imagine that you have some physician prescribing high dose corticosteroids in case of, the patient may receive that from the pharmacy, but can keep it at home in case of relapse. So we may be not really sure about the timing of the outcomes, right? And in another hand, you can also ask the question, I mean, do all patients with a relapse attend a neurologist visit and report their episodes? So I think that in both sides, we may miss some patients or we may have some false positive. Other point of discussion, so what is the impact of such uncertainty on potential study results? I mean, this is neither a very easy question to address, right? Because it depends on many factors. So first, is the algorithm used for inclusion criteria? Is it used for outcome identification? So in the case of the latter, I mean, it really depends also on the study type and objective. I mean, if we try to assess the burden of a disease with the bias algorithm, you'll have bias incidence rates. Whereas if you are dealing with comparative analysis, well, you can always hope that there is no differential bias in the different cohorts, and you may expect perhaps a different impact on the results. And the last point, which is obvious, it's, well, what are the potential expected bias? So what are we missing in our data? Again, in the same example, if you are dealing with only primary care data, well, you can expect that you are missing stuff that are managed in hospital settings. Few words to conclude. Well, first, the standard methodology may not always be applicable. So if we consider that Shabi is our student, so please be creative and find a way to validate your work. That's something important. And so the most important question again for me is, I mean, is your gold standard really gold? Because it's very tough to find a gold standard, as we discussed it earlier with Vera. So please carefully assess the gold standard that you will be considering for your validation study, because it may also be biased. And so the last sentence, it's obvious, but it's always good to say, well, please carefully consider the impact of potential bias on your results. And that's it. You can have your coffee.
You can have your coffee. You deserve a coffee unless there are immediate questions. There is one immediate question, but go back. Nicolas, here.
When you validate your outcomes in SNDS, you take advantage of the longitudinal information that you have there. What if what if there are cases of your outcomes with high lethality? For example, in metastatic castration-resistant prostate cancer, patients who have received 4 lines of treatment are likely to die very soon. If you exploit the longitudinal information, you might be losing high lethal cases. How might that impact?
Well, the good point is that we have no gap. So, in one point, if you have a multiple metastatic castration-resistant prostate cancer, you had IRM, right? You have imaging procedures, you were hospitalized, you received treatments, even sometimes. I mean, what you are really missing in the SNDS is everything that happened outside of the hospital. So you have, I think that for the MCRPC, you have a low rate of missing people. Who you really miss, it's people with, for example, a myocardial infarction, because that might happen at home. And in this case, you have no contact with the healthcare system and you are missing people. But you are right. I mean, if you have a MCRPC patient that is diagnosed and died just after, you may miss it because you will not have enough information pieces. But even in this case, I mean, I'm not sure that you will find in any data source that this patient died because of the MCRPC, right?
You may have cause of death. You do have that.
Yeah, well, that's a trick. We have cause of death, but we have a delay before having the cause of death in the database. So we usually have 2 to 3. I mean, they are improving, they are greatly improving, but now you need to wait for 2 to 3 years to have the cause of death linked to the claims of the database. So if you work in recent years, sometimes you have to use algorithm to derive cause of death.
Yeah, you could use death at all, and then as a screening algorithm somehow, and then maybe you can validate the old years and then propagate somehow.
Yeah, that's a very nice idea, and we are currently working on that actually with Laure again.
When you have an almost perfect person that gives you advice. Thank you very much, Nicola.